7:32, I will get started, and then I'll go a little bit slow for other people to catch up as they join us. And today's clinical case, a very brief overview of it. I did put it in the invite. I hope you guys were able to see that. I will also paste today's clinical case in the chat box, so you can refer to it at any time. So having said that, let me officially welcome all of you. Good evening. My name is Anup Agrawal. I'm an interventional cardiologist at Care Hospital in Hyderabad. I'm joined in this weekly huddle by my colleague and co-host for the session, Dr. Praneeth Polamari. The weekly huddle is an unscripted audience-level interaction where we address common clinical scenarios, recent research findings, news, lifestyle, among others. And we aim to keep the discussion patient practice oriented, something that we do practically in our day-to-day life. We typically pick up a topic or a clinical case and restrict our discussion around that so that we reduce the vagueness. We try to focus on that particular patient that we are discussing. The basic premise of the huddle is to bring our casual hallway discussions to a more organized platform like this one and share our ideas. While science and guidelines are welcome in this discussion, the huddle intends to help a physician translate what is established knowledge to what we do in our clinical practice, taking our local factors and local practical patterns into account. We host this weekly huddle every Wednesday at 7:30 in the evening, like one today. And this is our 34th session. For today, we'll be discussing acute deep venous thrombosis. And my apologies to the huddle attendees for the last session where I couldn't join. I was participating in a TAVR proctorship, so couldn't get out on time. To facilitate the discussion today, we have Dr. PC Gupta joining us. He's a vascular surgeon well known to most of us. And we'll get his insight as well for this particular session. So the way typically we go about is I speak out the clinical case. I ask my co-host Praneeth for his initial impression, and then we open it up for audience interaction. This is not a speaker model. This is more of an audience interaction model. So at any given time, if you have any thoughts to share, you can raise your hand or wait for the other person to finish and then unmute yourself and share your ideas. Essentially, the target is to share our ideas together and maybe learn a few tips or tricks in between. So Praneeth, here is the case for you, and then I would ask for your clinical opinion on this. So this patient I saw last month. He is a 40-year-old male. He is IT professional by profession, a vegetarian guy, no known medical issue. He otherwise minds his own business. Last month, he had to visit family at Nagpur. So he decided, because of this COVID and whatnot, that he will take his own car rather than taking a flight or something or a bus. So he drove, and he came back 4 or 5 days before I saw him. And this time he drove straight from Nagpur all the way down to Hyderabad. So he came to the OPD with the main complaint of diffuse swelling and aching pain involving the right leg. And this had started insidious onset about 3-4 days. And now it is getting much worse. This pain is something that increases when he tries to move his legs a little bit. So that is literally what brings him to the hospital. He doesn't have any fever, doesn't have any chest discomfort, no breathing issues. He never had these problems before. There is no family history of any clotting disorders. On his examination, he has this unilateral swelling involving the right leg, which extends from the feet all the way up to knees. In fact, it involves the lower portion of thighs as well. There is no erythema. There is some warmth and global tenderness all across the leg. With the clinical suspicion of acute DVT, I ordered an ultrasound, and that suggested external iliac, common femoral, and popliteal vein. They were all non-compressible, dilated, with hypoechoic intraluminal debris that was consistent with acute thrombosis. The left leg was checked and that had normal compressibility. So here we have, I kind of summarized a little bit. I didn't give you all the details just so that we keep it quite concise. So here we have a 40-year-old male with what looks like a precipitated acute DVT, probably related to the long driving. So the question here is, what will be the initial management strategy? And in the invitation, I kind of put in few things to lead us our discussion. The questions for you to answer, Praneeth, is what are the kind of clinical evaluations that you are going to do at this point in this patient? And in terms of management strategy, the questions are going to be inpatient versus outpatient, heparin products plus vitamin K antagonist versus novel anticoagulants, whether you will think of doing any catheter-based therapy, yes or no, whether you will put him on antiplatelet right away, yes or no, and would you like to do any further workup about his DVT in terms of precipitating factors? And clinically, he does not have any signs of pulmonary embolism. What is your threshold of checking for pulmonary embolism? So a lot of these questions are there, Praneeth. In the next 5 minutes, if you could give your approach to this patient, and then we'll ask our audience. Praneeth.
Yeah. Good evening, everyone. As you pointed out, the diagnosis is already made, acute DVT. So regarding the choice of treatment, heparin plus warfarin versus novel oral anticoagulants, I would start this patient on heparin, and preferably because he has only an acute lower limb DVT, though the extent is the entire leg. Still, because he is hemodynamically stable, the suspicion of pulmonary embolism is low. I would tempted to treat this patient on outpatient basis, and preferably start him with low molecular weight heparin, prefilled syringes, which are there, easy to administer, kind of teach him, and attempted to treat him on an OPD basis, no antiplatelets, and try to figure out what is his reach to hospital and knowledge about this thing. And if I'm confident that he understands the problem and he can reach to medical attention if there is anything, any problem is there, I would be trying to teach him, treat him on an OPD basis. Call him back after a week's time and see how he is doing. And based on the week's status, I would try to take a call on how do we move forward. If he continues to show improvement and he gets better, start him on novel oral anticoagulants and ask him to continue. Versus if he doesn't show any improvement, I would try to look into catheter-based therapies, trying to relieve the thrombus burden and establish the flow. That is how I would try to look at this patient.
And Praneeth, question is, do you do routine ECG echocardiogram on every new DVT diagnosis, or you do it only if there are symptoms?
ECG definitely I would do. Echo not much, because clinically he doesn't seem to be having any tachycardia, no respiratory distress. I doubt echo will add any further value to the existing investigation, because clinical suspicion being low, the probability of echo staying normal is high. So I don't think echo will add much of a value to the existing investigations.
And other than routine labs like hemogram and renal function, anything else that you check in these guys on the very first time, or you reserve it for special cases?
I would definitely try to look into whether he has any procoagulant condition or a prothrombotic tendency. But because these tests are some things which have their limitations in relation to giving anticoagulant therapy, I would keep this in the back of the mind, but try to treat him first. And once he kind of gets out of this situation, I would look into working on the procoagulant states.
Perfect. Thanks, Praneeth. Let me ask other people in the audience about how they would go about in this particular case. Anybody in the audience, if they have any thoughts, they can please raise your hands and I will call out your name. I'm just going to pick up a few of the cardiologists in the audience and ask their opinion, how they would approach this. We have Dr. Chandramukhi with us. Dr. Chandramukhi is a senior cardiologist at Care Banjara, and she's an expert echocardiographer. Dr. Chandramukhi, I hope you heard this case. It's a 40-year-old male with acute DVT, which most likely is precipitated because of long car ride. He has got a painful right leg. How would you go about this case? And the questions are inpatient versus outpatient, heparin, warfarin versus NOVAC, initial investigations, and whether you choose catheter-based intervention or not. Chandramukhi ma'am.
Good evening all. So as a patient, as already pointed out by Dr. Praneeth, that patient is hemodynamically stable. We can treat this patient on outpatient basis. And we can start on low molecular weight heparin, like pre-filled syringes, because it is convenient for the patient to take it at home. And then after a week or like that, we can switch over to oral anticoagulations, either NOACs or direct anticoagulators. And at this point of time, I would like to do the ECG, and also echo can also be done because it is easily available and and it can be readily done in our outpatient center. So I would like to do echo also, because in some cases, some patients may have subtle symptoms we may not be able to make out, and sometimes we have some additional information on echo. And that coagulation profile and other things, because it is acute stage, we will wait for now, and later on, once after 4 weeks or like that, we can plan for ruling out any procoagulant states. Catheter based therapy in this case, I would not prefer in this case.
Perfect. Thank you so much, ma'am. Let me pick up a few others in the audience. We have Dr. Suri Prakash with us. I believe he's joining for the first time in the huddle. Welcome, Dr. Suri Prakash. For those who don't know him, he is a very senior cardiologist at Care Mushirabad. In fact, a one-man show there. Dr. Suri Prakash, if you're able to hear me, can you please unmute yourself and tell us how would you approach this particular patient? Dr. Suri Prakash, I hope you're able to hear me. Okay, there may be some technical issue there. Let me ask somebody else. Dr. Prithvi, I hope you heard the clinical case and the questions related to that. If you could unmute yourself and share your initial thoughts about this particular case. Dr. Prithvi.
Yeah. Good evening, sir. Good evening, everyone. So, as our seniors have shown previously, I'd also like to treat him as an OPD basis only, sir, as the vitals are stable. And initially start him, I will directly start him on NOVAC, sir. So, and it is easy for him before injections sometimes can be difficult. And I'd also like to postpone the investigations regarding flow coagulant profile, sir, because it's an acute event. And I'll clearly explain him about the symptoms regarding the pulmonary embolism, so such that he won't be in trouble again later. And I'd also not prefer to thrombolize this patient. The catheter-based interventions are not true, sir.
Perfect. Thank you very much, Dr. Prithvi. Dr. Prashant, are you able to hear me? Dr. Prashant Vazirani. Yeah, if you could share your thoughts on this clinical case, please.
Sure, sir. What I heard, it is a proximal DVT, and if the patient is stable, then I usually put the patients on NOAC. If the patient is absolutely stable, there are no other red flag signs. If the patient is showing, and call him back after a week, and order the routine investigations like if it is a provoked or unprovoked DVT, just try to make that out, and if it is an unprovoked, then look into the procoagulant factors like protein CS deficiency and other factors.
Perfect. Thank you, Dr. Prashant. Let me ask Dr. PC Gupta. He is a vascular surgeon and he is my special guest for today. Dr. Gupta, I have got some specific questions for you. This patient, God knows why he came to my OPD, technically for a leg problem or for a vascular problem. There is a very high chance he would land up in a vascular clinic to begin with. How do you see patients like these in terms of their clinical management? And my particular question to you is, how do you see role of catheter-based therapy in these cases?
So, I think there are two ways to look at acute DVT. Is it Iliofemoral DVT or is it sort of more distal DVT? If it's a patient with Iliofemoral DVT, I definitely look at the catheter-based therapies as one of the first line options, provided certain criteria are fulfilled. One, a relatively younger patient, this patient fits into that criteria. Number two, patient should be able to afford therapy. Number three, there should be no major risk of bleeding. If these criteria are met, I would offer catheter-based therapy as the first line because there is enough evidence to show, and we also see it in our clinical practice, the incidence of severe post-thrombotic syndrome comes down very, very significantly when we use these therapies. So that is how I would proceed. And for me, it is not waiting for a week that I would actually decide on this therapy. Because if I wait for a week, patient would definitely be symptomatically better. And I don't think any patient who's actually getting better would agree to an invasive therapy. The best time to intervene is as early as possible. As time goes by, the chances of clot dissolving completely keep coming down. So early institution, I prefer to do it within a week, maximum within 2 weeks.
And sir, what is your thought on the selection of anticoagulant?
So if I start with anticoagulation, I generally start with low molecular weight heparin and not conventional heparin because again, trials have shown that LMWH has sort of more reliable bioavailability and efficacy compared to heparin, for which the patient would typically need to be hospitalized with monitoring of APTT. And whatever I have seen in the wards or the ICUs, the APTT monitoring is generally not up to the mark. And patients are either over anticoagulated or under anticoagulated. So I'm very happy to use low molecular weight heparin to start with. And then depending again on the patient's affordability, switch over to vitamin K antagonists or to the NOACs if I'm going to continue with anticoagulation alone. If the patient is a candidate for thrombolytic therapy or catheter-based therapy, then I continue LMWH till the patient is sort of prepared. And then after catheter-based therapy, I switch over to anticoagulants.
Perfect. Thank you so much, sir. Let me get more thoughts from the audience. We have Dr. Shankar with us. Dr. Shankar is a senior physician. Dr. Shankar, this kind of case, I'm sure you see it quite routinely. You have an acute DVT, kind of non-complicated, and you have got two differences in opinion. You have got cardiologist, which are categorically saying that we treat outpatient and we treat with either low molecular weight heparin or with NOVAX. And you have got a vascular surgeon who says that his first line therapy for this particular case, which is a Iliofemoral DVT in a low risk patient, a low risk for procedure patient, he would offer catheter as the first therapy. Dr. Shankar, how do you see in your practice?
Good evening all. This is a case of proximal DVT, Iliofemoral DVT. It is actually when a patient comes with the Iliofemoral DVT, when we diagnose, here it is not there. It is not a limb-threatening or a life-threatening situation here. I generally treat it as I put him on low molecular weight heparin, and followed by 1 week I will give low molecular weight heparin, and later, depending on the patient's pocket, I switch on to BKA or NOVAX. But I convince him to take NOVAX at least for 3 months in this case. But as Dr. P.C. Gupta told, that is also one school of thought, because most of the patients actually with the Iliofemoral DVT, in my clinical practice, I have seen 50% of the patients have come with a post-thrombotic syndrome in the form of either venous edema or venous claudication or hyperpigmentation, venous ulcers also. So I prefer to, in case of Iliofemoral DVT, which is a proximal DVT, I prefer to send him to a vascular surgeon to take care of catheter-induced, catheter-directed thrombolysis or the surgical thrombectomy if it is essential.
And Dr. Shankar, one specific question for you. How do you see this 40-year-old guy with no other comorbidities, vegetarian guy? How much do you think vitamin B12 deficiency or not thereof plays a role in this kind of situation? Is it too much advertised, or you think it's a real deal?
Homocysteine, hyperhomocystinemia is one of the risk factors for the deviant thrombosis. That's why probably that B12 might have been thought of, I think.
But is it something which is routine for your practice in terms
No,
of
I
look
don't
for
think,
it?
I have not used routinely.
Perfect. Thank you so much, sir. And during the course of discussion, if you do have any other suggestion, please unmute yourself and share your thought. Let me look for other audience member. Dr. Santosh is with us. Dr. Santosh is a junior consultant cardiologist at Care Hospital, Banjara Hills. Dr. Santosh, I'm sure you heard the clinical case. If this patient comes to your OPD, how would you manage? Give us your thoughts about it and whether you agree and disagree with the discussion so far going on.
Sir, I agree with Dr. P.C. Mehta sir's opinion. Such an extensive Iliofemoral DVT, I think CBT-based therapy will be the first choice, followed by then I prefer OPD-based treatment, sir.
Perfect. Thank you so much. Let me up the ante a little bit. We have Dr. Somaraju with us, and he doesn't need any introduction. Sir, you have heard some senior cardiologists, some young guys, some young consultant like me, Praneeth, and Dr. P.C. Gupta. There is mostly consensus in how we are going to treat, except some discussion about low molecular weight versus NOVAC to begin with, inpatient versus outpatient, because if you do have to do catheter-based therapy, you will have to put him inpatient. Sir, how do you see these kind of cases, and do you think we need to be more aggressive early on than what we are? Dr. Somaraju.
Yeah, Anup, for asking me. And if I have this problem myself, if my physician or cardiologist doesn't admit me, I will sue them. This is a very serious disorder, cannot be taken seriously. Absence of symptoms doesn't rule out pulmonary emboli, particularly distal part of pulmonary circulation. He has to be treated as if he already had a pulmonary emboli. Then, okay, B12 I'll definitely do. That's my prejudice. He's a vegetarian and unexpectedly this happened. I will also check whether there is a family history of things and somebody has already talked about it. And then this patient, we have to learn from, say, there are clinical trials available to support what Dr. Gupta said. Enough clinical trials now, some of them ongoing. The mechano-pharmacological therapy has to be urgently started because learn from acute myocardial infarction and primary PCI. There used to be discussions on whether thrombolytic therapy is better or PCI is better. When a thrombus occurs in the coronary artery and the thrombus is a long segment, none of the drugs reach the whole thrombus, particularly distal part of thrombus. Only pharmacological therapy will help? The answers are very straightforward and simple. He needs an echocardiogram. Not to do an echocardiogram is inadequate medicine. And absence of symptoms should not be interpreted. Pulmonary embolism is one of the very important conditions, one of the commonest conditions missed by routine clinical practices, including emergency. So I admit him, and I'll prefer that he has to be evaluated urgently and then treated as if we already had a pulmonary embolism. I agree with Dr. Gupta, and while I do mechanopharmacotherapy, I may even think of, if the, depending upon the results of other tests I suggested, even IVC filter while I go on doing all these things. Thank you.
Thank you so much, sir. We will talk about IVC filter. Let me just add my thoughts for 2-3 minutes, and then we will go back to our audience and we will discuss this again. So whenever I choose these kind of cases, I have a motive. I'm like, we're all selfish guys. We have motive. And whenever I see these kind of situations, I realize that there is a lot of inertia amongst us, and amongst us means all of us. We are all guilty of this for every single thing, that certain things we practiced in a certain way, and that kind of continued with it. So this is a real patient, by the way. It was not last month, though it was last year. But the idea here is few things which have been already brought about and few things which I want to add. Number one, acute DVT, I think as a cardiologist, we should start taking it as acute MI, what Dr. Somaraju was saying, that this was one thing which I was taught, this was one thing that we wanted to practice in a very aggressive manner. But obviously the baseline disease doesn't seem to be that aggressive to begin with. Oh, it's just a DVT. So, and treatment works. You give them anticoagulation within 24, 48 hours, then pain gets better, and all of a sudden you all feel happy about it. So for some reason, this thing didn't get as much of attention as it should. So in my opinion, and what even some of the consensus would suggest, that all acute painful DVT should deserve at least a day or two of admission for all the evaluation. Subclinical pulmonary thromboembolism, I check it in all of my patients. That is something that should be done. I actually go one step up. I do check high sensitivity troponin in these patients, because sometimes that could be the only marker of RV strain. And even a mildly positive high sensitivity troponin is an absolute indication for admission, because that is associated with very high mortality. I think NOAC works immediately. So if my intention is to put NOAC, then there is no reason to start low molecular weight heparin. Low molecular weight heparin starts working within 30 minutes. NOAC starts working within 2 hours. So you have got about 1.5 hours of lead in low molecular weight heparin, which truly is not that big of a deal. You don't do that for acute pulmonary embolism, because there you want them to hit as hard as possible. Early on, I do check for some of the thrombotic disorders like factor V Leiden or ATP3 mutation, because for those two, you can do it at any given time. For the other, like protein C, protein S deficiency, all the levels that you check, like protein C level, protein S level, those you can't do it in the acute setting. But the mutation part, that you can do it in acute setting, like factor V Leiden and ATP3. One of the main reason why I brought this DVT topic in today's discussion is because of post-thrombotic syndrome. And this is something which is understood in the last decade or so. We have been seeing papers about it. And as Dr. Shankar was saying, the incidence could be as high as 50% in these patients which present in one form or the another. And particularly young people who have to lead an active life. This is something that we should be looking for whenever we are treating acute DVT. And the practical tip that Dr. P.C. Gupta suggested, that if you send this patient home, they get so much better within a week of therapy that after that, to convince them to get a catheter-based therapy, it may be too difficult. I never think of that way, but that's a very practical approach of looking at. So probably the best time to do catheter-based thrombolysis is right on the very first day that the patient comes. And one thing that has not been discussed yet is a lot of these patients, they have some sort of venous stenosis, not all of them. But a lot of these patients, we end up finding that they have some venous stenosis, either of the deep iliac system or somewhere in the iliofemoral system. And sometimes they actually require stenting because that might be the precipitating factor why they developed thrombosis in this particular situation. So I think we did cover a little bit of it. And of course, the science is not crystal clear, but more and more thought is going towards preventing post-thrombotic syndrome and trying to go after this disease far more aggressively than what we currently do. So my checklist is routine labs, factor 5, ATP3, APTT, PTINR, B12. I do check ECG, echocardiogram, troponin, high sensitivity troponin, not the regular troponin, because regular troponin often comes normal. Admit, talk about catheter-based thrombolysis. If the patient is agreeable, we do that. If the patient is not agreeable, then at least for a day or two, we look for everything else, and then decide on which direction we are going to go. So that is the overall idea. I told you my intention of bringing this topic, and we will open the discussion one more time, and we will go through it. So let me ask, we have Dr. Anand. Dr. Anand is our DNB pass out. He's a cardiologist. Dr. Anand, you heard the clinical case, you heard the initial discussion, you heard what the big boss had to say, and you heard my overall rant. What is your thought about this case, and anything that you want to add?
Sir, good evening to all, sir. Very happy to talk to you all after some time. Sir, I missed the first initial presentation, but I could surmise somehow the overall presentation of the patient. Sir, what was taught to me and what I also believe is what Samaraj has said and what we have faced in care before. The landmark is the inguinal ligament. Usually, if the DVT is below the inguinal ligament, that particularly below knee or just in the popliteal artery vein region, we can go with anticoagulation alone, observe, and obviously the patient has to be admitted and observed. But if the venous thrombosis crosses the inguinal ligament and becomes an Iliofemoral DVT, better to go for catheter-based therapies. One thing which I have doubts about is the regimen for thrombolysis. Because it is not well standardized. We have alteplase and we have used tenecteplase, and for poor patients we have used streptokinase also, even for catheter-based therapies. And the second thing which I have noted in 2 of our patients is heparin resistance. So along with tenecteplase, we start them on heparin infusion, but whenever we check the APTT or even ACT, we find that we are not able to reach this therapeutic levels. These are the 2 concerns. So after that, and the other thing is the high risk of bleeding. And in some of the patients, we have noted hemoglobin dropping drastically. Popliteal hematomas. Most of our patients, we go through popliteal vein access, and we see huge some hematomas developing. And even though we take a micropuncture and take all precautions, the risk of bleeding is there. Heparin resistance is there. And one of our patients, we seriously debated whether the patient developed compartment syndrome, particularly in the calf region. So therapy-wise, obviously, a catheter-based therapy for an iliofemoral DVT, even the current guidelines plus records show that it is superior to prevent pulmonary embolism. But at the same time, we have some doubts regarding regimen, risk of bleeding, and other complications, and particularly heparin resistance.
Perfect. Thank you, Anand. Over the course, we will address some of the questions that you put up. Let me ask Praneeth again. Praneeth, if you could just share your thoughts in terms of what all you heard And do you think that the aggressive role of catheter-based therapies, we haven't talked about which kind of catheter-based therapies, we're just talking about a catheter-based therapy. And do you think that the aggressive approach of DVT is something which is justified, or you think that is being too much? And your thoughts on this?
Yes, catheter-based therapy, I agree and believe that it improves the patency rates of the venous system and prevents the post-thrombotic syndrome, which is what we want to achieve. But the issues which I have is how practically we can make it available, and the available centers and the available expertise, and doing it on a regular basis, and affordability of the patient. That is where it gets up. But wherever possible, and if it is available, yes, definitely it has to be offered. But practically speaking, because of its cost associated, it takes a back step. That is my concern.
Perfect. Thank you, Praneeth. And actually, I was hoping somebody would bring this up, because that will give me a reason to go back to Dr. P.C. Gupta. Gupta sir, I have few particular questions, and next 10 minutes, the floor is yours. I just want you to share your thoughts about these particular things. The question are one that Praneeth asks, that the practical limitations are the most difficult part when a patient hits your OPD in terms of trying to address the seriousness of the problem and trying to get them admitted. My specific question to you is the need for venogram. Do you do venogram in the patients? Second, role of Ibc filter that somebody brought up for the catheter-based therapy as a preemptive Ibc filter for catheter-based therapies. Third question is, when we talk about catheter-based therapy, there are three kinds of broadly divided catheter-based therapy. Either it is purely mechanical, like you just take a guide catheter, go in, macerate the clot, just pull out as much as possible, like a thrombosuction we do. So it's a pure mechanical aspiration, and one of the mechanical aspiration is angiojet, versus something like a catheter-based thrombolysis, where you take a catheter, dig it deep into the clot, and give thrombolytics in there. And there we can talk about what kind of thrombolytic, and it is typically placed for 12-24 hours. And the third option is a combination, where you have got some sort of ultrasonic catheter that you dig deep. It causes ultrasonic wave, and at the same time delivers thrombolytic, something like an ecosystem or something. So we have got three different categories of catheter-based thrombolysis. And lastly, how do you handle hyperkalemia in these situations? So Dr. P.C. Gupta, I've got a lot of questions for you. For the next 10 minutes, if you could just give us an idea about practical issues and some of these tips and tricks of how we do it.
Okay. I'll start at the beginning once again. When the patient comes to the clinic, we do a baseline evaluation, and in my practice, an echocardiogram is an absolute must, as Dr. Somraju pointed out. We do need to evaluate for risk stratification whether the patient has any evidence of PTE or not. And as I mentioned in the chat, we did do a study, and we found that almost 40% of people who do not have symptoms of PTE actually have PTE. So it's important for us to know. And coming to the therapies, we have the option of pure anticoagulation, we have the option of a surgical thrombectomy, and then we have the option of a catheter-based therapy. In the catheter-based therapy, we can have a catheter-directed thrombolysis, which means we insert a catheter into the clot and then give a continuous infusion, which may continue from 24 hours to 72 hours or even longer, depending on the response. And intermittently, we would do a venogram. I do not do a venogram preoperatively. Venogram is part of the procedure. The other way is a pharmacomechanical, as Dr. Somraju had pointed out. We have various devices which we can use for this. Ecosystem you mentioned, the angiojet that you mentioned, then penumbra we have, then the trellis, which has never become very popular. These are various devices. None of them are purely mechanical or suction. Any mechanical device is combined with thrombolysis. The advantage of using a mechanical device is that the clot clearance is much faster, more efficient compared to just catheter-directed thrombolysis. And it brings down the dose of thrombolytic agent also. And a concern was raised about risk of bleeding. That would definitely bring down the risk of bleeding. An ultrasound-guided puncture of the popliteal vein, if it's a good puncture without sort of going through arterial branches or venous branches, the risk of a significant popliteal hematoma is very, very low. Intracranial bleeding, as we see with high-dose thrombolysis like we give for acute MI or PTE, is extremely rare with catheter-based thrombolysis. Hyperkalemia is not a problem with thrombolytic therapy. When we use angiojet, we do see a lot of hemoglobinuria, and we prefer to hydrate these patients till the urine becomes absolutely clear. And this usually takes about 12 to 18 hours. Hyperkalemia itself is not a problem. The other advantage, besides reducing the risk, the incidence, and the severity of post-thrombotic syndrome, what catheter-based therapies also achieve is a reduced clot burden in the long run. And it has also been shown that reduced clot burden will reduce the incidence of recurrent DVT in future. This is what I would like to say now, but I'm open to any questions or anything that I may have missed. You can go ahead and ask me again.
Sir, role of
IBC filter. So when we use catheter-directed thrombolysis alone, we do not use an IBC filter, and we've never had a problem with that. However, when we use pharmacomechanical, that is either angiojet or penumbra, we do put a temporary IBC filter. And I think the most important thing putting these IBC filters is to ensure that after 6 to 8 weeks, you remove these filters. Do not leave the patients with filters lifelong.
Perfect. Thank you so much, sir. If anybody has any questions or comments, I think that we did talk a little bit about deviating or changing the usual narrative of how we treat DVT. If anybody has any questions or comments, please feel free to raise your hand or unmute yourself. In the meantime, I'm just going to read through some of the questions which has been posted in the chat, which has not been answered so far. So Dr. Zakaria asked if choice of NOVAC. So let me put up the most recent question. Choice of NOVAC. Dr. Kota asks what choice of NOVAC. So I will answer that question. You have got direct thrombin inhibitor, which is dabigatran, and then you have got a 10A inhibitors, which are rivaroxaban and apixaban. I prefer 10A inhibitors, and I'm sure pretty much all of us prefers 10A inhibitors if cost is not an issue. And amongst rivaroxaban and apixaban, really it doesn't matter which one you choose. Important thing is all the thrombotic lesions like DVT, pulmonary embolism, and all this, they have a loading dose for this NOVAC. So don't just put them on 10, 15 milligrams of rivaroxaban or 5 milligrams twice a day or 2.5 twice a day of apixaban. There is a loading dose, and typically the loading dose for rivaroxaban is 30 milligrams a day. You can choose to give it for a week or 2 weeks. For pulmonary embolism, we tend to give it for 3 weeks. And the same thing is for apixaban. You load them with 7.5 milligrams twice a day for a few days, and then change it to 5 milligrams twice a day. Remember, these drugs are best. These drugs work best if taken with food. Otherwise, their absorption is not very good, and they typically start working within 2 hours. So that is the overall. If you do end up taking dabigatran, you just have to tell the patients that these drugs are hygroscopic. That means if left to atmosphere, they will absorb moisture, and absorbing moisture leads them to higher bleeding incidence, typically GI bleed. So with dabigatran molecule, that is one thing that you have to see. The tartrate content of individual dabigatran molecule needs to be seen because now there are so many brands available. One thing good to know is rivaroxaban prices have come down. The drug used to cost 145 rupees per tablet. Now the cost is around 58 rupees per tablet. So it's almost 1/3 of what it used to cost. Same in the line of dabigatran. So rivaroxaban can be used, and apixaban also there are few brands which are of slightly lower price. So that is the choice of Novak. The other question that comes is, and if anybody has got any difference in opinion, please raise your hand or unmute yourself. I'm just killing the time by reading some of the questions here. If long-term morbidity due to post-thrombotic syndrome is taken into consideration, which treatment option is of choice, mechanical versus pharmacomechanical versus pharmacotherapy alone? Dr. PC Gupta, if you could take this question, if the long-term morbidity due to post-thrombotic syndrome, if that is the target for us to treat, which one would you prefer? Angiojet versus your penumbra versus simply just putting a catheter and putting anticoagulation?
I have answered this question, Anup. Pharmacotherapy alone, that is using NOACs or LMWH or VKA, the risk of PTS would be the highest. Intervention would bring down the risk of PTS with Iliofemoral DVT. There is little to choose between catheter-directed thrombolysis alone versus pharmacomechanical. Pharmacomechanical definitely makes it more efficient. The clot removal is faster. So it's a shorter procedure. Probably will reduce the ICU stay as well as the hospital stay. The catheter may add to the cost, but some of the cost would be offset by reduced ICU stay. And of course, it would also bring down the dose of lytic agent. So what really would be the determinant of post-thrombotic syndrome is how efficient is the clot clearance. So the more efficient the clot clearance, the lower the risk of post-thrombotic syndrome, which means again that we need to do these therapies as early as possible. Now, once there is a delay, let's say we've reached about 2 weeks, then what I have seen in clinical practice is that the catheter-directed thrombolysis alone is not enough to lyse most of the clot. In that case, adding a mechanical thing like angiojet definitely makes a huge difference to the outcome and would be more efficient than catheter-directed thrombolysis alone.
Sir, to the audience, give us an idea about the cost we are talking about, pharmacomechanical, in terms of, let's say, putting an angiojet or something and then following it with a 12-24 hours anticoagulation. Give us an idea of the cost that we're talking about.
The angiojet catheter costs about $1 lakh. They can be sometimes reused, sometimes the reuse fails. And since we don't have an angiojet machine with the hospital, the company charges 50,000 as rental for the machine. So that's 1.5 lakhs for the hardware. And then, of course, maybe about 20 milligrams of altiplase we would end up using. So total, we are looking at about 2.5 to 3 lakhs. And if we uncover a stenosis in the iliac vein, in the specialized venous stents, the stent cost is again approximately $1 lakh. So you can do the math. So we're looking at about 3 to 4 lakhs, depending on whether we need to do a venous stenting or not.
And sir, you briefly answered my next question. Your drug of choice for thrombolytic, and you mentioned it is altiplase, if I'm getting it correct. Achha, sir, when I came to India, I was talking to one of my seniors about this whole angiojet business and everything, and he said we have a cheap way of doing it, and that is we take a 8 French multi-purpose guide, just shove it into the clot, we macerate it and suck as much as possible, and then use the same catheter, make some holes, and do altiplase through that. What do you think? It's a poor man's therapy, or it is total disaster?
No, it does work. There are a lot of people who do it, and we have also done it. The problem with the 8F guide is that it tends to collapse. So sometimes the suction may not be efficient, and you definitely need to combine that with thrombolysis. It can work, no doubt about that.
Perfect, perfect. Okay.
It's going to take as long as catheter-directed thrombolysis. Now, some of the clot will not really reduce the duration of thrombolysis in this patient. The angiojet, once you are done with the procedure, generally there is very little left, and if at all you need to continue thrombolysis, it may be for another 12 hours or so. So the whole process is done in less than 24 hours.
Perfect. I'm just going to read through some of the other questions, and If anybody has any thought, they can unmute themselves. So how does the treatment change with the finding of elevated high sensitivity troponin? Because I said I do it, so I'm going to answer this question. Basically, if the patient has got elevated high sensitivity troponin, that tells me that even if all the markers and tests for pulmonary embolism, even if they are negative, this patient did have pulmonary embolism because high sensitivity troponin positivity in the absence of any other myocardial dysfunction like ACS, myocarditis, and all those things. In all likelihood, it indicates RV strain. And these patients, they should be admitted, even if we are not planning any inpatient catheter-based therapy, because otherwise, for a low-risk pure DVT with echo ECG and all these other tests normal, people are hard-pressed to get admitted. So whenever you have an elevated high sensitivity troponin, you just assume these patients have subclinical pulmonary thromboembolism. Admit them in the hospital, initiate therapy while they are in the hospital, observe them for a day or two, make sure they are walking around doing okay, they're not developing any sinus tachycardia or anything early on. And then after 24, 48 hours of observation, you can send them home. So that's how I practice. I tend to be a little bit more aggressive with DVT, both in terms of pulmonary thromboembolism and also in terms of offering them catheter-based thrombolysis, although my success of patients accepting that is very low. And that's a practical issue of telling the patient to spend that much of money, which is probably a skill that over the time we learn. Okay, so I'm going towards more questions. In the meantime, anybody else has any thoughts, please feel free to put in. I'm just going through the questions here. How much does catheter-based therapy cost? I think that we have already addressed. How many days of hospitalization is required? That also we have addressed briefly. So angiojet plus thrombolytic, patient may go home in about 48 hours or so. And if you're doing a catheter-based thrombolysis alone, then you're looking at maybe 3 days, maybe 4 days of hospital stay with somewhere between 1 to 2 days of catheter treatment. What if the patient is found to have thrombocytopenia? I think Dr. Gupta answered this question already. These patients may have consumption thrombocytopenia, and if you treat them, their platelet count improve. But remember, we'll have to look at HIT as well in these patients. Remember, heparin-induced thrombocytopenia will present as both thrombocytopenia as well as thrombosis. So if you have a correct patient set, somebody who was in the hospital or somebody who got some test or whatnot done, now comes in with clot and thrombocytopenia, remember, HIT will have both the components. It will have thrombocytopenia component as well as thrombosis component. And then for most part, if you treat with anticoagulation, they improve. For HIT, you treat with ergotroban. For non-HIT, you treat with everything that we discussed. So those are all the questions in the comment box that I addressed. Okay. Anybody else have any other thoughts that we discussed? Dr. Suri Prakash, we wanted to hear your thought. Last time we couldn't get you on board. If you're able to hear us, could you please unmute yourself and share your thoughts about this case? Dr. Suri Prakash? Okay, some technical issue there. Dr. Chandramukhi, if you could unmute yourself and tell us what your thoughts are for the discussion that we had so far in terms of catheter-based thrombolysis and in terms of being aggressive with DVT. And after you, Dr. Shankar, I'm coming to you after this. Dr. Chandramukhi.
After hearing all the discussion, I would definitely discuss with the patient regarding the catheter-based therapy, and if he's willing, then we will do the catheter-based therapy, and we will admit this patient and treat this patient.
Dr. Shankar, your comments, please.
See, instead of low molecular weight heparin like enoxaparin, can we use a fandaparinox because it is once a day, and at the same time we can avoid even HIT also, a heparin-induced thrombocytopenia. What is the opinion of the house? I want to know.
Dr. Gupta, would you like to take this question? Fondaparinux versus enoxaparin?
It's a controversial thing. Yeah. So which is better to use with thrombocytopenia? There is no definite answer. There is always a concern that LMWH or heparin might induce HIT and cause further thrombocytopenia. And definitely fondaparinux does not do that. However, the risk of bleeding could be slightly higher with fondaparinux. So I prefer to use dalteparin when there is a borderline platelet count and I'm clear that patient has not been exposed to heparin earlier and that definitely this is not HIT. Dalteparin seems to have a lower incidence of affecting the platelets and a lower risk of bleeding. And I think in most of these patients, the platelets do come up over 2 to 3 days, and then you can go on with your standard therapy.
So Dr. Shankar, in my training program, we did used to use fondaparinux quite a lot. And we wouldn't initiate in somebody who had or who is suspected of HIT because there is cross reactivity still present. So there the drug of choice is argatroban or bivalirudin. But to start with as a first line therapy, fondaparinux certainly seems to be a very reasonable alternative to low molecular weight heparin. Is it superior in efficacy or safety? I don't think so. I think, as Dr. Gupta pointed out, maybe you may end up having with a touch of more bleeding. Fondaparinux got a bad name amongst cardiologists because the trials showed that when these patients go for a catheter-based therapy like angiogram or angioplasty, they tend to develop a lot of catheter thrombosis. So that is how fondaparinux got a very bad name amongst cardiologists and anybody who works in a catheter-based therapy. So that is why Fonda kind of got out of favor. But as a single agent, it's a wonderful drug, and we have used it multiple times. I think that should be okay.
Thank you.
For people who have established HIT, for them, Fonda is not the treatment of option that I want to emphasize again and again. There is cross-reactivity between fondaparinux and low molecular weight heparin. If you have a patient with suspicion of HIT or diagnosed HIT, the treatment option are argatroban or bivalirudin, not fondaparinux. Anybody else? Anand, do you have anything to add? Unmuted. Okay, no, probably by mistake. One question that was not answered, one question that I did put up which was not answered. Dr. Gupta, do you put these patients on antiplatelet?
Put these patients on?
Antiplatelet agents, aspirin or clopidogrel.
No, unless I have put a stent, then I do give a low dose aspirin along with anticoagulants, but otherwise I do not put them on antiplatelets.
So you know how this, I myself was saying how the old habits die hard. I personally used to give them low dose aspirin when I would treat them with warfarin or acetrom, and I would not give them a low dose aspirin if I'm treating them with NOAC. And that is my 3-year-old habit, and I don't know if there is any scientific basis to it, but that is what I used to do, like for no rhyme or reason. Low dose aspirin along with warfarin versus no aspirin when I give only NOAC. And if you have a venous stent, then of course, then you have to give aspirin. One question that came is during catheter-directed thrombolysis, should we prefer heparin infusion or low molecular weight heparin? Before that question I asked Dr. PC Gupta, I do want to highlight, Anand, you were mentioning one thing about heparin infusion and the APT target. Let me make it very clear to everybody. If you are giving thrombolytic to your patient, please give them anticoagulation. Even if whatever the EPTT says, please give them anticoagulation unless they're going to go into a disseminated clotting cascade. It's a disaster. If you are giving them thrombolytic agent for anything, you can wait for an hour or two, that's a different thing. But if you are giving thrombolysis, anticoagulation is a must. There is no question about it. and then whether we should prefer heparin infusion or low molecular weight heparin. I'll ask Dr. PC Gupta to answer this question. During catheter-directed thrombolysis. PC, sir.
Yeah. During catheter-directed thrombolysis, we use only heparin infusion and not low molecular weight heparin. The aim is to prevent any thrombosis around the catheter. And again, the monitoring, I think it's important for all of us to understand that when we are using thrombolytic infusion along with heparin, we like to monitor the APTT and we also like to monitor the serum fibrinogen, though that is controversial. A lot of people say it is unnecessary. But in my practice, I still prefer to monitor serum fibrinogen. And if the levels fall below 100, then I would prefer to just suspend the thrombolysis for some time and wait and then restart once the fibrinogen levels come up. With very low serum fibrinogen levels, the risk of bleeding would be high.
Perfect. One of the question, and this is the last question we are going to take. We are at 8:33. Does treatment option vary if candidate is pregnant? And Dr. Zakaria, I think the treatment option is going to vary. Certainly, you wouldn't want to give them radiation unless they're at the very end of their pregnancy. And you certainly wouldn't want to give them any warfarin acetrom, except the middle part of the pregnancy. You certainly wouldn't want to give them NOACs because that has not been tested. So patients who are pregnant, they have very, unfortunately, the treatment options are very limited. And the safest drug would be heparin. And in the middle of your pregnancy, you can give them warfarin if you want to. So anybody has any thoughts about how to treat pregnant ladies? Dr. Gupta, could you just share your thought of how to treat DVT in pregnant lady in terms of therapy?
Yeah, look, I think as we pointed out, the majority of the ladies with pregnancy would be managed with LMWH. Warfarin can be given after the first trimester. Since during the first trimester, it would be teratogenic. And then towards the end of pregnancy, we would again switch them back to LMWH. In pregnant ladies who present with thickened limbs, let's say putting the term correctly, phlegmasia ceruleus dolens, where there is impending venous gangrene, then we do have the option of going in either for a venous thrombectomy or for a thrombolytic therapy as a means of helping preserve that limb.
Perfect. Thank you, sir.
Definitely.
Yeah. One more question that was brought up, and this is the last one. Why is heparin resistance more in DVT than during ACS? So Anand, I will tell you, because I have like a pseudo experience in India now. Whenever we talk about heparin resistance, the most common reason I have observed of heparin resistance is poor quality drug. So if you do have heparin resistance in your patients, just give them another batch of heparin and see if it works, because many of the times in my ACS patients, the cause of resistance was just a poor quality drug rather than the biology itself. So, and then if there is a biology behind it, that's something we can discuss. So having said that, it's 8:36, it's time to wrap up. I would again invite Dr. Somaraju for his closing comments, anything that we missed or anything that we highlighted more than what we should do, and if he has any closing remarks on this topic. Dr. Somaraju.
I think most of the issues are already addressed, and it's wrong not to admit this patient. I want to say that more than once. And secondly, when post-thrombotic syndrome patients, the study showed that say they have venous stenosis, 100% of them will have post-thrombotic syndrome. And as Dr. Gupta suggested, they are the ones who need some stenting or some intervention. And post-thrombotic syndrome is a miserable experience. And lastly, I just want to comment. While you are doctors, you are talking about cost of treatment and all that. You have the medical authority of a kind which nobody else has. The authority of clinical and responsible medicine requires that you have to individualize patients. Wherever, whichever platform you are practicing, patients should not be denied just because it's costly. And it depends upon the type of patient. This type of patient who is a software engineer, some of you talking about cost tells me you are already confused about the way we have to treat our patients and the cost involved. Even lesser costs and lesser patients who can afford less, we have to be able to treat them, and we have to insist upon this wherever you work. That's the reason why I left care at the point I left. Thank you.
Perfect. Thank you so much, sir. Gupta sir, so next time when we call you and say that we need to do angiojet on a patient free of cost, we need to figure out some way to do it. I'm just kidding.
No, it's a very difficult topic,
Yeah.
and I would not get into arguments on this. But yes, cost, while it is not that the reason that we say we should not offer a therapy, we should offer a therapy irrespective of the cost. This patient definitely no reason why we should even be thinking about the cost, because working in an IT company, he's likely to be covered by insurance and there should be no problem at all. However, any private hospital is not going to be able to bear the cost of expensive disposables, and that is something we need to keep in mind. All of us are concerned about patient care and patient welfare and do a lot of procedures free and give a lot of discounts on our professional fee. We cannot expect the hospitals always to come and put that bill, because hospitals have to run. You cannot let the hospital go into losses, because then they will shut down. So I think that is my take on coming to the costs. As far as costing for the patients are concerned, it's extremely important that we look at the financial health of the organization while we are trying to help the patient. See, I cannot ultimately do charity by burning my own house. That is something I need to keep in mind. But at the same time, if I can help a patient from my professional fee, I do it, and I've been doing it. So, cost consideration, then no doubt.
Dr. Gupta, we are going to close this session. This is the first time you joining us. If you could just give us your comments about the format, not the content, the format of the discussion. Constructive criticism.
I think we've had a fairly good discussion and a lot of points have been covered. And I think it will vary from topic to topic. For DVT, I think this worked quite well.
Perfect. Thank you so much, sir. Praneeth, your closing comments, and then we'll be done.
Yeah, so thank you everyone for that discussion. Yes, many points learned. So all acute DVT patients need to be treated or taken seriously, need admission for a day or two, observe whether they are slipping to pulmonary embolism and escalate therapy accordingly. Do look into markers to get your comfort zone, high sensitive troponin, or maybe other investigations to know it. All the patients, try to give them the option of catheter-directed therapies, and try to think that as a first-line therapy, and if we can't, then look at other options. And thrombolytic therapies, again, preferred drug being alteplase, recommended and all. And the younger the patient, the more aggressive we are, and probably team-based discussion is something which will bring out the best for the patient. That's what I could conclude from today's Huddle session.
Perfect. Thank you so much, Praneeth, and thank you for all the attendees for attending today's session. Special thanks to Dr. PC Gupta for joining me. To the attendees, particularly those joining us for the first time, we would like your feedback. So if you have anything to suggest to us, please write to me, or you can text me, call me, whatever. If you find the session worthwhile, maybe request you to share it amongst your colleagues so that more and more people can interact in our discussion, because the whole motive is thought sharing. As I said before, the Huddle is hosted every Wednesday at 7:30 p.m. The link that you clicked to join the session today, the same link works for future session as well. And the ID and password is also static, which means you can use the same ID and same password for future sessions as well. All the sessions I download and upload it on podcast and YouTube. I'm obviously lazy, so I run late in uploading those, but eventually they will show up on the podcast and YouTube. You can simply just go on your favorite podcast or platforms and search the weekly huddle. If you want a particular recording, just shoot me an email and I'll send it to you. I thank you again for your time participating in this. Good night, and hopefully I'll see all of you next week. Thank you. I'm closing this session. Thank you all.
Thanks, Anu.